Welcome to Complicating the Narrative, a podcast that takes on the challenging questions in public health by embracing complexity rather than avoiding it. I'm your host, Salma Abdallah, an assistant professor at Washington University School of Public Health. Today, we're diving into an increasingly important topic: health communication. The ways people encounter information about health profoundly shape how they perceive risks, how they act, and ultimately their health outcomes. In an era of information overload, depolarization, and declining trust in institutions, health communication is more complicated than ever. Consider this paradox. The same techniques that can make health messaging more effective, personalization, emotional resonance, social proof, can also be exploited to spread false information, especially in the age of social media. The algorithms that can deliver life-saving diabetes management tips to exactly the right people at the right time can also deliver misleading health claims with surgical precision. We are operating in a world where the tools of persuasion are more powerful than ever, but the foundation of trust that health communication depends on is fragile. Another question we have to ask ourselves as people increasingly push against public health messaging is, how do we design health communication strategies that meet people where they are, while also respecting autonomy and differing values? To help us wrestle with those questions, I'm joined by Dr. Matt Kreuter, one of the leading figures in health communication. Matt is professor and director of the Health Communication Research Lab at Washington University in St. Louis. He's the author of Tailoring Health Messages, a foundational textbook that helps shape how we think about personalized health communication in the field. Matt, welcome to the podcast.
It's great to be here, Selma.
Yeah, so before we start, and I've been doing this with all of my guests, hopefully people are listening who are not just focused on health communication, but are also in different parts of the public health, I would say, sphere, might not necessarily know a lot about your background. So maybe you can tell us a bit about how you moved from being an English major to health communication to public health. And did you always envision that you would want to connect communication and health communication theory with population health practice?
Yeah, I didn't. Actually, like as a kid, I was not a great student, but I was a good writer, and I liked writing, and so I did, all the writing for the school paper kinds of things that students with that interest sometimes do. And when I went to college, just at the local state university, they didn't have a journalism program, which is what I was most interested in. So I became an English major for the writing more than the literature. And I put myself through school doing what we would call media relations now. So this is like the early 1980s. And so it's legacy media. And I was writing press releases for, local TV stations and radio stations and newspapers. And when I graduated, like that was the most marketable skill I had. And so I worked, my first few jobs were in media relations. And at one of them, I was tasked with setting up a daily radio news service in Iowa. And so every day we would come up with stories and we'd send notifications out to like 100 small town local radio stations in Iowa. And on a really good day, we might get a quarter of them to run the story that we came up with. But after doing that for a couple of years, I just kept having the feeling that there must be some greater outcome than media coverage that these tools could be used for. And I must have been complaining about that to the right person. And someone said to me, well, have you ever heard of social marketing? And I'd never heard of social marketing. And I went to the library and I looked up social marketing. I found an article by Phil Kotler and I read it and I thought, oh my Lord, this is what I'm supposed to be doing. This is what I want to do. And I tried to find programs where I could learn. Where could I go to graduate school and learn about social marketing? And I found none. But I did find that there were some professors at North Carolina, UNC Chapel Hill, who were doing work in social marketing. So I applied there, and they happened to be in a school of public health. And so I ended up at UNC Chapel Hill in the School of Public Health, and I fell in love with public health. And so since that moment, I've been working at the intersection of communication and public health. And so that was my path to health communication.
That's really interesting. Was there a particular moment where you thought, actually, how we say something is as important as what we say? Or was it just more of a path dependency where it was clear, yes, this is important, but it also is something I'm interested in and I will move forward with it? And I'm only asking this because I realize, and I love all of our public health colleagues, clearly they care a lot about public health, but it's rare, I guess, comparatively, to find someone who does a lot of public health work who also really appreciates the importance of health communication.
Well, I guess I think this certainly wasn't in my mind at that time, but it's
Mm.
something that I recognize looking back. To be effective as a communicator, as a journalist, you have to be able to convey ideas in ways that are sort of clear and concise. And we haven't always been really good at that in science in general and public health specifically. And so I do suspect that was an advantage,
Mm.
sort of going into health communication. Now, so I land at North Carolina, and I get connected with a professor there by the name of Vic Strecker, who was this super innovative, very kind of forward thinking and entrepreneurial scientist who was interested in health and communication. And one of the things that Vic had observed is that the way we were communicating health to the public at that point was very much a one size fits all approach. And so, and this is this is the late 1980s.
Mm.
And, and Vic said, like if you just go to a doctor's office, like there was at the time kind of the ubiquitous pamphlet rack. And that's how we conveyed information to people. One set of information for everybody, in a printed, tri-fold brochure. Um, and he said, like, we just have to be able to do better than that. And his hypothesis was that if you could find out a little bit about each person, each individual, you could provide them not with a one size fits all pamphlet, but you could provide them with exactly the information that they needed to, make health improvements. And he called this idea tailoring.
Mm.
And what we what we did in those very first tailoring studies is we would create these short little surveys, maybe 8, 10, 12 questions, and we'd ask people these questions about their health, like if they were smokers, like 12 questions about their smoking habits. And then based on how they answered those, we could provide them with not generic, but very specific sets of recommendations that would be helpful to them, based on kind of the context of their behavior and their lives. And at this time, this is like the beginning of the desktop publishing revolution. So suddenly
Mm.
you could have printers sitting at your desk, and you could create one version of something. And so we started writing these simple little computer programs that would process instantly the survey responses from people and produce, for our desktop printer, a personalized health communication for somebody about,
Mm.
helping them quit smoking, for example. Um, and that was sort of the dawn of tailoring, and it worked. It was more effective than general communication at getting people to quit smoking, getting people to get mammograms, changing their diet, getting parents to vaccinate their kids. Um, and so that was really cool. And I think what was most exciting about it um, was that it had the potential for kind of mass customization, like to be able to do this at scale, which is important for public health, right? Like this is not a some sort of miracle thinking. Like any good counselor does this. You ask people questions, you listen to the answers, and then you customize how you respond. That's not new. But being able to do it on a mass scale with computers, that was new. The
Yeah.
cruel irony is, of course, that the approach that we took of making observations about people, like getting information from and about people and using it to customize information that we gave them, that's now what drives our information ecosystem in a way that's probably, not healthy and certainly wasn't what we intended.
Yeah. As a true health communicator, you're setting me up very well, because now you've answered maybe, or you've moved me in the direction of two areas I actually really want to ask you about today. So this
Okay.
is just great.
Okay.
So I think I really want to dig deeper into the concept of tailoring, and maybe right now also in this era that we're living in. So I will get back to it later, especially because I've read some of your earlier papers and I have a few questions that I would love to learn more about as someone who's not a health communications expert.
Sure.
But I think maybe as a starting point, and as you did mention, you started thinking about tailoring health messaging a long, long time ago, and you wrote tailoring health messages about 20 years ago, I think now maybe. But the landscape,
At least it feels like twice that, but a
yeah.
while ago. Yeah.
But the field, I think, has changed, exactly as you said, it changed drastically. But so how would you define health communications in 2025? And what do you think fundamentally changed, given what you just said about how algorithms are using now exactly those tailoring health messaging techniques?
Yeah. So just to be clear, and I think your listeners certainly understand this, but we're at a point now where every single bit of information that you give people intentionally, but much more commonly unintentionally, every keystroke, every website you visit, every word you text, every word you say in a phone conversation is captured and can be used, can be sold, but can be used and applied to determine what information you're going to see, and what people want to sell you, or what ideas they want you to believe, or what candidate they want you to support. And so, like, that's been happening for quite a while. That's not new, but it does fundamentally change how people get information. And I think the evidence is strong that it contributes to some of the things you mentioned in your lead about um, polarization, for example. And also, I think in some ways, the danger is that um, if you look at simply the amount of information, not just health information, but information in general that is available to people, that's getting produced, that's getting shared, that's getting consumed, it's increasing exponentially. And that's been going on for a long time. And as humans, we just don't really have the capacity, and increasingly don't have the desire to process it all. And so we rely on shortcuts. And we also, I don't know that we depend on it, but it's all processed and filtered for us so that we're only seeing, a part of the world that somebody thinks we want to see,
Yeah.
or can see. And that's wildly different than the information environment that I started in the field in, where you had legacy media of, a few TV networks and, local newspapers. Now there's an infinite number of sources. So it's much more complicated. And I don't know if you want to go here, but like at the current moment, the health information ecosystem is immensely complex, and I think not all that healthy.
Hmm. Yeah. And I think it makes me wonder, seeing what's happening right now. Can you look back? I was trying to think about what would be a complicating the narrative approach to health tailoring of health communication. And a question there would be, did you think at the time that you were doing this, that from the beginning, crafting a message that would focus maybe on someone's gender, their ethnicity, their income level, their education level, or even their health beliefs, did you think from the beginning that that could be taken further to maybe reinforce stereotypes? Or could someone even argue, as we argue right now, in some of the false information that exists out there, that that could lead to someone being manipulated, or just maybe telling people what they should hear instead of what allowing them, as previous traditional campaigns would say, just would do, just sharing everything for the general public and then having everyone just take from it what they need to take?
Yeah, I actually think we did know about that, but the scale was different. So
Yeah.
um, even in those early days, we're deeply engaged in the practice of what we call audience segmentation, right? So the idea was that you could identify population subgroups that were homogeneous with respect to some attributes that you were interested in. So if you were selling product X or idea Y, What are the groups of people to whom you might communicate in the same way about that idea or product? And, sort of simple or lazy audience segmentation or targeting could say, okay, well, this is, we want this for young people and we want this for Black people, like simple demographics. But most audience segmentation was a bit more sophisticated than that. But still, the premise was that you could create communication, information, marketing for subgroups, and it would be specific to the subgroups, and it would be more effective. So like that idea that's been around for a long time. Doing it at the level of the individual person, one person, and what they think and believe and consume. That's what's been, I think, different and transformational about the current age. To your question about like, um, making incorrect assumptions, if you will, or inaccurate inferences about a particular group, I think there's lots of evidence of that too. And I don't know that that's an inherent flaw to trying to customize information as much as it is poor execution, or just not really thinking about the consequences.
Yeah.
So, like one example of that would be, you often see in public transportation areas. At least I'll just use the example of St. Louis. If you look at communications, advertisements, public service announcements that are, at bus stops and on train stations, they are often targeting people who are perceived to ride public transportation, lower income groups, minority groups, and they're often addressing topics that are, sort of, they convey problems. And there's certainly a risk, I think, that reinforces stereotypes or is stigmatizing in ways that sort of convey unintentionally that these people have these problems. That's an unintended consequence, but a preventable one, of customization at sort of a group level.
Well, how would you prevent that?
Well, like in the example that I gave, or just
Yeah, yeah.
more generally.
Yeah, generally, so I was thinking, like, can you think of maybe a tailoring campaign that maybe has gone wrong? Not necessarily yours, but something that has tried to customize in the past that got wrong. But also, what would be best practices to maybe escape the issue of having customization reinforcing stereotyping?
Yeah. So m- when most people think about if you were to ask people like what's health communication, most people, the first thing that comes to their mind and the first thing they say is messaging. Oh, it's messages. I would argue that the most important part of health communication is actually listening.
Hmm.
And so my answer to your question about like what went wrong and how you would prevent it would be much more effort, and systematic, sort of investment in listening. And so you wouldn't make those mistakes. You'd be less likely to make those mistakes if you were engaged at all stages of the process with people who you were trying to, um, reach with that particular information. Because if you
Hmm.
did, um, you'd pick up signals and hints that this might not be having the impact or being received in the way you intended.
Do you think there might be also a larger harm of and I'm just here thinking through this. It might work well with the intended audience of listening, but then could the tailoring on the bus in St. Louis also be seen by other groups that then reinforce stereotypes about the group that is intended for? So it works with the specific group, but then other groups can look at it and think, oh, this means the specific issue is really focused on that specific group, and that
Yeah.
reinforces stereotype. Yeah.
Yeah. So we actually did we did a number of studies about this, around the topic of, racial health disparities.
Mm.
And for as long as, which is an issue that I care deeply about, and most of our work is related to that. And um, most of the way that racial disparities have been communicated to the public are in these black-white comparisons, usually in the US, where the data, the evidence overwhelmingly shows that African Americans have a higher risk of or bear a disproportionate burden of X, fill in the
Yes.
blank. It sort of doesn't matter what it is. Any health problem, policing, mortgage rates, um, pick whatever that is. And we wanted to know, like, how did people, like, that's one way of framing um, racial health disparities, is that there are differences between groups. But there are other ways to convey that same information without making a comparison to another racial group. Like, for example, let's just look over time. Like, is this group doing better? Are they getting worse? And so we actually examined in these experiments, how would people react to
Mm.
comparative racial information versus just like progress over time? And the results were really stunning. And what they showed over and over again is that um, these racial comparisons were, in fact, they made people angry. They made them experience a lot of negative emotions. They made them less interested, not more, in engaging in whatever the desired behavior was. And my diagnosis of this is that well-intentioned public health folks, in our field, felt like, and well-intentioned journalists, to be honest, um, really saw this as an issue, as an injustice issue, and that if we could just call it out, it would get attention and um, it would be motivating to people. And that may have been true if the audience was legislators and policymakers, but for the public, exactly the opposite. Exactly the opposite is what's happening. So I think that's another example where good intentions and maybe not enough sort of consideration of unintended consequences led to decades of communicating in a way that was fairly harmful.
Yeah. That is really interesting. And I actually do really like the fact that, and I very much appreciate it as someone who writes about social and economic health gaps, and I mostly focus on the economic health gaps that we don't necessarily usually think about. Like, what does the message? Like, when I write about it, I am really interested and deeply interested in the policy changes that lead to those health gaps. But I don't necessarily think about, like, how does the public perceive this. So I always appreciate the fact, at least reading through your papers, that you're thinking more about, well, if you write it this way, is the idea there to actually change policies, or is the idea there to create maybe a public movement of thinking about, like, how can we change things? And if that is the case, are we writing it in a way that actually leads to change? Are we writing our papers in a way that leads to change? And to be completely honest, I've never thought about this before, so it was it was helpful going through your papers over the past few weeks, which actually leads me to two papers or two projects that you've been doing recently that I think are fascinating. One of them, I have so many questions about the methods. Not an attack on the methods. I'm just really interested
It's
in
going
what
to be
you
an
did.
attack. I
Yeah,
feel
yeah.
it.
Yeah. But the first one is the iHeart STL surveillance and response system that you've done, I think, in the early years of COVID. I find fascinating. So maybe just tell the audience a bit about what you did there, and we'll talk a bit about the methods. I have a few questions, but also the what were your conclusions from that work?
Yeah. So let's go back to like January of 2021. So we're about a year into the COVID pandemic, and vaccines are becoming available. And I'm on the phone with the health director for St. Louis County, Summer Schmidt, and Summer is saying, "Our people out there on the front lines are just getting all of these questions about the vaccine that just don't seem accurate, and they don't really have answers to them, in the moment, and it's kind of creating this tension um, in the community." And during that call, we decided that what we could do together was build a kind of a community listening infrastructure where we could ask people in St. Louis every week, "What are you hearing?" And are you believing it, and where are you hearing it from? And then we could quickly turn that information around to equip frontline workers with accurate information and ways that they could respond when they were hearing claims that were unfamiliar to them. And so that was the genesis of I Heard. And we've now been doing it. We're now in our 5th year of doing it. Still, every single week, we survey 200 plus people in St. Louis, and we've done this in 7 other states now too.
Hmm.
Um, and we really just want to know, like, what are you hearing about health? What questions do you have? What trying to identify what people know and what they don't know, what they're concerned about. And this survey goes out on Saturday afternoons, and it's open for 48 hours. And so by Monday afternoon, we're able to look at responses and try to identify in communities sort of the most important health issue that needs attention. And then we can create accurate, actionable responses and put those in the hands of community organizations that are working on health. And so it's this community listening and rapid response to put information in the hands of community members that has like that's what I Heard has been doing.
Yeah.
Does that?
Yeah, no, that's great. And I think I have 2 questions. I actually really appreciate the fact that this has been going on for 5 years, and it's one of the few methods that I've seen that are just very fast paced. So you just almost real time information provided to community organizations that is very helpful for people. I do think so. 2 questions about the methods in general, and I think then I have a specific question about the results, at least from the paper that I've seen in the plus one paper. So the method, it just made me think conceptually, thinking about what you said about tailoring and how people perceive false information that they receive. Do you think, not in the open-ended questions, if I understood the method correctly, but the questions that ask people if they've seen a certain message, do you
Yeah.
think just reading that in a survey being sent by health communication group might actually plant some of the seeds of this false information in people's head, or not? Or was that one of the risks that you thought about, or you don't necessarily think that could be something that could happen?
Yeah. I don't think it's a question. I think it's like really solid science that when people are exposed to misinformation, even if the intention is to address it or counter it, it can have the effect of making it feel more accurate. Because I heard it, and at some point, people maybe don't distinguish where they heard it. They just know that they heard it.
Yeah.
So the way that we handle that within I Heard is that when we ask people if they've heard an inaccurate claim, we get their answer, and the next thing they see on their screen, these are mobile phone surveys, the next thing they see on their screen is the accurate information,
Okay, great.
whatever it is that we know. So it's not perfect, but hopefully it would counteract any any risk that hearing a false claim makes it feel real.
Yeah.
I think though, I would suggest, Salma, that at the heart of this question is an important fundamental principle of communication having an impact, and that is that um, when people hear the same thing um, from multiple sources that they trust, that's when communication can start to affect how people think and how they act. Does that make sense?
Yes.
It's actually that second voice that's really important and powerful. And so, from a public health perspective, this is a perpetual challenge. Like, how can we expose people to accurate information multiple times from multiple different sources that people trust? Does that make
Yes.
sense? And
Yes.
I don't think we've necessarily thought about how to do that. I think we've sort of stopped at, yeah, we should do that.
Yeah. Yeah.
Um,
Yeah, and I think this actually builds into my next question, because based on what you told me, I think so. just to help me understand, do you ask that same 200 people every week, or is it different 200 people?
Yeah, these are panels within a community,
Yes.
and they sometimes change over
Change.
time, and we add new people.
Yeah.
But yes, it's the same folks.
Because it was the same thing I thought about. So it could be that are they exposed the first time, but also I wonder sometimes two questions happening here. Is it, if it happens longitudinally, even if I didn't believe it the first time, even if you give me the accurate information, if you're asking me about something 4 or 5 or 6 weeks, I might start wondering, oh, maybe there is something to this. But
Yeah.
also I think relevant to it. And I will ask you about how you think we can move beyond based on the results that you found, which for that study at least, it was that once someone has that false belief, it's really hard to actually shake it, it's more stable to actually to continue having that false belief. And we really need to think more about what we do in public health and actually changing that false belief when someone has it. But I think also I was wondering, do we think the people who likely just don't believe in anything that we think is important to address in health are people who might not even fill out surveys like this. And I think those are just even more challenging. I think just looking at the results that you showed us, it made me think, oh, that group of people, I don't even know how do we reach them, because I'm not sure they even fill out surveys. Sorry,
Yeah.
too many questions here, but
Yeah, no, those are all good questions. Let's start with the last one. I
yeah.
don't buy that at all.
Okay.
I don't buy that there are um, groups that are unwilling to share what they think and are unwilling to fill out surveys.
Yeah.
I'm old enough and have been in the field long enough that there used to be an expression, hard to reach, the hard to
Interesting.
reach populations, and what that always meant were poor people of color usually, and what it really meant was that you know university people didn't know how to reach them, but 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 Walmart does, and lots of people do. So I just
Yeah.
don't buy that. I think that maybe it's not as familiar or comfortable for us, but I think that people are willing to share, and our panels have people who see the world in really different ways and aren't
Yeah.
afraid to share that.
Okay, that's
So
really great to know. Yeah, I think I was mostly thinking, if I am someone who hears every single day that public health is has conspiracy theories that wants to advance what pharmaceutical companies are selling, would I be even interested in filling out a survey that goes back to a public health entity? So this is really actually helpful to hear from
yeah,
you. Yeah.
I just don't think so, and I
Yeah.
think maybe part of that is the way that we do it. Like this is like we are not, iHeart is not a mouthpiece for public health, and it has no agenda and it has
Yeah.
no ideological leanings. What we're really trying to do is find out what are people hearing and what do they care about? What questions
Yeah.
do they have? Um, and people have questions and they have things that they wonder about.
Yeah.
So and I think there's actually maybe a bit more similarity there than people might expect. But
Yeah.
I think the more interesting question you're asking, and let's go there, is like how could we do this? Like how what might it look like if public health tried to do this? And we've been thinking a lot about this. And so if you were if you wanted to build kind of systems and structures that made it more likely that people encountered the same information multiple times from people that they trust, what would you have to do that? Not like I think the changing what people believe when it's false information, I think that's a losing proposition. Honestly, it's too late in the game, and it's not really addressing the problem. It's addressing an indicator of the problem. People believing misinformation is not the problem. That's
Yeah.
an indicator of a health information ecosystem that's producing that. I
Yeah.
think. So here's an example. You've got one of these, right?
Yeah.
So if you and I,
My best friend.
your best friend, if you and I, right now, if I said, Selma, tell me what the high temperature is going to be tomorrow in St. Louis. Like
Huh.
go to your favorite weather app and look at it. And I do the same thing. We're probably looking at different apps. Maybe we're on different phones, but we're going to be really close. We're going to be within a degree of each other, I predict. And if the listeners did the same thing, we would all be within a degree, no matter where we were in the world. Why is that? The reason is that almost all of those apps and almost all of the local TV forecasts are basing they're basing their predictions on the same set of data that's gathered by NOAA, which has the National Atmospheric and Oceanic Administration. Yeah. Or I probably have the letters mixed up, but they're constantly taking measurements of, water and air and temperatures, and those are available to people who make apps that, predict weather. What would an equivalent of that be? So, like in the weather information ecosystem, there's this kind of common understanding, if you will, of some of the key determinants, and it leads to relatively standardized information. I think in the health information ecosystem, we really lack that. Like there's no shared information or understanding about what the public knows and doesn't know, what the public wants to know, questions that the public has. And I think that if we could create something like that was, very immediate, very timely, and make it available almost as a public utility to people who work in health information, whether those are, influencers or journalists or health organizations, it could move us at least incrementally towards a bit more coordination, where certain health topics, kind of rise to the top at a given moment, and the public has these questions about it, so let's address those questions. The goal isn't to standardize information. You still want content creators to do things in their own authentic ways, customized to the people who follow them. But it would increase the odds that people would hear something that's accurate, that's actionable multiple times from different people that they trust. That to me feels like a gap in the current health information ecosystem, and one that's fillable.
Yeah. So it's so many questions, so many lanes I want to go to here, but I think just interestingly, I wonder sometimes also when we are at universities, when we're in public health departments, we talk to each other for a long time. I think a few years now, I've been using my mother. I don't know if she's listening to this. She is a university educated someone in Sudan. And she was telling me a few years ago about what she's reading on WhatsApp when it comes to how vaccines are bad for you. And I think at first I didn't really take it seriously. And I think I realized after a while, like a lot of the events or a lot of the things that we get surprised by in public health, those have been circulating for a long time among people on WhatsApp group and different groups. People who are in the US might necessarily know that WhatsApp is a big deal in different countries. And I've been really trying to say in Sudan, for example, is there a way beyond me just asking my mother every time she gets a message about health to forward it to me? Is there a way for us in a system like this that is mostly encrypted, very hard for someone to monitor, to be able to understand what are the conversations people are having about health? I think I would be really interested in this because the moment my mother talks to me about it, she's heard so many stories that is actually hard to get her to back off from what she thinks. I have the benefit of being her daughter and she trusts me. So sometimes the end of the conversation is me saying, you just really need to trust me on this. And she can, but I'm pretty sure that's going to be very hard to say that to millions of people. You just really need to trust me on this. So I think this really resonates with me. Is there a way for us to understand how people are thinking, what they're talking about, and how can we engage with them? The other thing that this made me think about what you were just saying is then how do we communicate in health communication? How do we help people with accurate information? I do think in public health, we struggle with also just saying sometimes that we are uncertain about something. Like, yes, this is what the majority of the evidence is saying, but we don't necessarily have 100% certainty. And I guess that's where also I wonder, how do we bridge that gap? Yes, understanding what people are thinking about and talking about, but also once we say, this is what we're communicating about, is there a way for us to communicate uncertainty in a way that makes it easier for us to come back later and say, no, we have more information. This is what changed.
Yeah. Lots of really good points there. First, just to say there are companies that track what information is circulating online and in social media spaces, including in places on the dark web that maybe are not as easily accessible. So that sort of tracking is happening, and I think that's really useful. I don't think it's enough on its own, because what it's really doing is tracking what's available, like what's in the universe, which is very different than what people are actually hearing and engaging with, right? So I think we need both. Like, we need to know what's potentially, theoretically, out there for people to encounter, but also what are they actually encountering? Does that make sense? So I think I think the best solution will have some of both of those. Now, to the uncertainty question, which I think COVID laid bare, the risks of ignoring uncertainty, and we can go into lots of examples there. But I think this is a really hard one. This is a hard one for scientists. I think scientists want to caveat everything and identify like every possible reason why a particular finding or a particular recommendation might not apply in all cases. And that's the sort of caution that we're trained as scientists to recognize, and acknowledge. But that is also pretty horrible as a public communication strategy, because then it feels so equivocal, and I think it's easy for people to dismiss. So like that's one side of it. Like, are you trying to have public impact and understanding, or are you trying to make the public into little mini scientists? And maybe the way I've framed that sort of tells you where I land. Now, during COVID, there was also the case where, boy, oh boy, that was such a dynamic time. I mean, things were changing often day by day, certainly week by week, what we understood. And I don't think we did a great job of conveying that things were going to be changing, and that we would tell people what we learned as things were changing. Instead, I think the approach we took was erring on the side of caution and health protection. These are the things you should do, and suppressing is too strong a word, but like not highlighting anything that might be perceived as detracting from those recommendations. And so this led to things like, many people believing that if you got vaccinated, you would never get infected. And then people got vaccinated and still got COVID, and we came up with a term for it, breakthrough infections. And really what the public thought, quite appropriately, was, your vaccines suck. Like these don't work. And that's not because they didn't work. It's because we didn't explain to people how they worked, or what we did and didn't know about how they would protect against this virus. So I think there are consequences of ignoring that.
Yeah. What would you recommend for someone also, if we're being completely honest, in public health, which I'm assuming people who get into public health are interested in protecting the health of the public as a whole. So we just have that bias as well. How do you communicate what you found in your science? Yes, you don't want to be too cautious, but you also don't want to be too certain. But also, how do you keep in mind your own biases or your own preferences of what you would want to do as an individual, and then not project that on an entire population? I think that's a very hard area that we haven't figured out yet what to do with in public health.
Yeah. And what makes you think I've figured out how to
You're
do
the
that?
health communication guy.
Well, I feel like there have been a lot of criticisms of public health, and a lot of criticisms of science recently for having sort of ideological leanings that
Yeah.
affect the questions that we ask and whose opinions we um, seek and sort of trust. And I think that some of those criticisms are honestly quite fair.
Hmm.
And so I hope that as scientists, we are, um, listening to that and sort of challenging ourselves to, um, you know, really consider many different perspectives on how, you know, on the questions that we're asking and interpreting the results that we have. And so I think this is a moment for um, kind of evolving professionally.
Hmm.
And so I hope people do that. I feel like our team and me personally, I'm trying to do that. So that's one way that we can do better. I guess the other response that comes to mind is that this isn't maybe exactly what you're asking, but it's important that we spend time on things that are consequential. Does
Hmm.
that make sense? Like
Yes.
there's a lot of information, there's a lot of health information out there that's maybe, interesting or curious, but it's not actually all that consequential in terms of um, how it affects people's health or their lives or their kids or their families. And so I would encourage us to use that sort of filter of consequence as well, so that we're not contributing to this um, ever growing sea of information for people to process or understand or ignore, but try to really challenge ourselves to find really meaning that's going to make a difference for people and focus in that area.
Hmm. I guess now I'm moving a bit. I think it's in the same realm here because we have increasing focus in public health, an area called misinformation. And I think you've used the term misinformation in your paper, and I have used it in a lot of my papers as well. I've read, and this, I think, to me, thinking also, how do we as scientists in public health maybe engage with the broader public includes, do we engage with other disciplines? I've read a paper, I don't know how correct it is or not because I'm not trained in philosophy, but it was a philosopher arguing that using the term misinformation is not necessarily helpful. Um, Information could be false, they could be inaccurate, and most of the people who use misinformation use it to add a value judgment on top of what they think the information reflects. I don't know where I stand on that, and I actually am hoping to have him join the podcast. Maybe we just need to find a way to communicate between public health and philosophy there. I don't know what you think about that
Yeah.
that perspective.
I agree with it. I think that term has become counterproductive. Maybe was always counterproductive, but it now carries a meaning that's quite judgmental,
Mm,
um, and it sort of implies that the person using it um, knows the right information, and the people who believe the misinformation, the M word, don't. Um, and I think in some ways that reinforces the idea of, there are know-it-alls, and then there, like you other people are in the dark. So
mm,
there's been, and quite recently, but writing that basically says it's also as a term, it's kind of lazy because what we lump a lot of things under that term misinformation that are really conceptually quite different. So, like, we would include things that were intentional deception,
yeah.
just as we would include things that were maybe incomplete
Mm,
or things that raised a question that might be perceived as you know asking about something that's not accurate,
yeah.
along with things that just aren't accurate or they're not completely accurate. So I'm actually we don't we refer to it as the M word, and we don't use it.
Interesting. Oh, okay. I actually thought I was going to get more pushback. I think you used it in 2020 and I used it as well. Now I use more false information, or if I think something is deceptive, I say deceptive just based on that paper. I need to think about it more. I thought we were getting here. You're going to give me a pushback, and I'm hoping I'll bring you and him to the conversation. Maybe we'll have a debate and then see who wins. But this is actually really interesting. We'll see. We'll see. Hopefully he will be able to join the podcast. I guess maybe just quickly before we move into the future and thinking about the future of health communication, I would love to hear a bit more about your 211 project. I just think it's fascinating. And just maybe as someone who's a data nerd, I'm just realizing as I read more of your work, there is so much data that you're working with. I don't know how to convince you to maybe share some of your data with me, but I don't know what I would do with it. But there's a lot of data that you're working with. And I find that refreshing in a world where we usually take a lot of time with our public health data to do something. So can you tell us just a bit about that project?
Yeah. And there's a theme here that you'll recognize as well, which is, I use the example of the weather apps on our phone using, starting with kind of a common set of data, a common understanding of conditions. So let's talk about 211. 211 is a 3-digit phone number, like 911 for emergency. If you're in the US or a lot of other places in North America and even some beyond there, if you dial 211, your call is going to go to an operator, like someone on a phone in a call center near you. And that person is sitting in front of a computer, and that computer is connected to a database that has thousands of health and human service resources that are available in your community. And they're going to listen to the caller and try to figure out what it is they need, and then see if there's an organization near them that might be able to help. So who calls 211? Mostly people who don't make enough money to live in today's society, and they need help. So they might need help paying a utility bill or paying rent. They might need help getting food to feed their family or a mattress for a child. And so this system, which exists, all across the U.S., is taking these calls, tens of thousands of calls every single day across the U.S. And what 211 does that's really remarkable is they have this extensive taxonomy of needs, over 10,000 needs, and when people request help, they're able to capture what kind of help that person needs. Does that make sense?
Yes.
So I discovered 211 in a meeting at a local foundation, and the foundation board was meeting, and they have to approve all of these proposals. And I was in there waiting my turn, and 211 was presenting, like, we want, funding to help support this new service, 211. And I was just blown away. Like I chased their representative out in the hallway afterwards and said, we must work together. Long story short, 211s were collecting all this data about what people's needs were, but they weren't doing anything with it. Like it would appear maybe in an annual report or something like that. And we really felt like if we could get that information in front of decision makers, in front of people, who are in a position to allocate resources or set priorities for communities, it would be a really valuable resource. And so now, like 14 years ago, we set up a system called 211 Counts. I would love users to go to 211 Counts and explore the data in their community. But 211 Counts now shares the information on the social needs of communities in near real time. If you went on there right now, you'd be able to see what people called about in your community yesterday. And it's a really powerful tool for understanding what people need, what people are struggling with at a community level. And this is like these are ground truths, right? Like this is not like people speculating about, well, we have this problem over here. This is what human beings are saying on the phone to another human being yesterday. I need help with X. So So that's really powerful. And it also allows us to see like what kinds of issues are, emerging, what's rising that we ought to be paying attention to.
Are there any specific plans on what to do with it next?
Yeah, so we have we've set up these public-facing dashboards in over 100 communities so that people and leaders can see the information, and like they're getting a lot of eyes. Like those the visits to those sites are quite substantial. COVID really drew a lot of people to those resources, but I think we need to be much more proactive about getting the data stories to people who can act on them instead of sort of hoping that they go and find the data stories themselves. So that's the future of 211 of 211 counts is to really apply advanced data science methods to recognize early on patterns in the data that human eyes might not pick up, looking at only one community, and then to share that for action with influentials and media types.
And we'll put that link to 211 accounts in the show notes so people can access it. And if you
Great.
have any ideas, I'm volunteering Matt's email to you. You can just email him about what could be done next.
Yeah, love that.
I think we touched on that a bit throughout the conversation, but I think the looming question here, if someone is listening to this and thinking, well, health communication or tailoring health messages or whatever we're saying today is basically just a tactic to address the symptoms, and you've talked about this earlier today. And instead of thinking more about what is the foundational problem here, it is lack of trust. It is that we're not really thinking about what people think about on a daily basis and engaging with the issues that they care about most instead of the issues that we care about. And I think links to that also thinking, how do we engage with people who have very different values than the value that public health might be pushing, which is improving your health outcomes? Maybe someone values more being able to live a risk-taking, shorter life than a risk-averse, maybe more risk-averse, longer life. And how do we engage with people who have different values and different views without actually talking past each other?
Yeah, I do think that I, I think let's put health information in the broader context of public health, right? So um, there are like 10 core functions of public health, and communicating information to the public is one of those. But like that's not the solution to some of the root causes of health problems in communities. And doing a better job with communicating, whether that's listening or messaging, is not going to erase those health problems. But it's an important part of what we endeavor to do as public health to bring about those changes. And I think again I would go back to listening and say that I think where we're going to make where communication can make a big difference in the broader public health priorities is really making sure that we are asking all people, and listening to you know what they want and need in their lives out of health and health information, and trying to provide that in a way that's meaningful in the context of their lives. And I think we're infinitely capable of doing that, but I don't think we have done a very good job of it historically. And so putting in place more systems and structures that allow us to capture that information and do that listening so that it can inform what we do um, is a really important step in the right direction.
I must say, so I agree on one end. On one hand, I think maybe that's a conversation for a different podcast. I
That sounds
struggle
like you
with this.
disagree.
No, so I agree. I fully agree with everything that you said, but I think at the same time, and is an additional function that we should think about, where we're part of also being a scientist or someone who's passionate about changing an issue, is that you need to lead, even if an issue is not coming up as what people think are concerned with. So I think that's where I usually struggle. And I think about this a lot also when it comes to community engagement, where it is great to hear from the community what they know their needs are. But I think sometimes it is helpful to also take the lead of thinking about, like, what are the larger issues here that might be impacting what people think on a daily basis. I think that's what I usually struggle with. It's how do we have a good balance between engaging with the people on the daily needs or the things they are really concerned with, but also not losing what I would think of as our responsibility to also think at a larger scale about, like, what other things, what more systematic things needs to change. And I just don't know how to draw that line between listening and then engaging immediately, but also trying to lead the way of, like, what needs to be changed. And
Yeah.
sometimes, yeah, sometimes things affect people that they don't necessarily think of that as important for them on a daily basis. What do we do with that?
Yeah, that's a really that's an important addition to this. I appreciate you adding that. I do think I think that's important. I think kind of a related observation and something that our team has been thinking about is that
Yeah.
um, people are interested in solutions, but most of them don't know what solutions are possible,
Mm,
right? So pick any big problem. Like think about like homelessness or housing affordability as issues. People can identify that as a problem, but most folks don't know, oh, well, like here are 6 strategies that have been deployed in different communities that seem to be working or have promise. And I think this is another direction where we can grow is to engage the public more purposefully in sort of vetting solutions that are available, right?
yeah,
Like, okay, like here are some things that we could do. None of these might be you know, the complete answer that we need, but here are some things that have helped elsewhere. What would work here? Um, and I think like those are conversations that I'm really interested in.
yeah.
I'm always surprised by um, I'm always surprised by the sort of richness of the insights and kind of depth of thinking and candor when you just talk to people.
Yeah.
And so I'm actually pretty bullish on what we can gain by doing a better job of listening and engaging community members.
Okay, great. So one last question here before I just and I promise I'll finish just thinking about the future of health communication. But one last question here, maybe, do you think we're teaching our students to actually engage deeply on what it means to communicate with the broader public, what it means to actually engage with people who have differing values, differing worldviews, who might not necessarily want to listen to the things that we think they should care about, but they have other priorities that they care about? And what do you think we actually need to do to make sure that that is a skill students graduate with?
Oh, you're bringing up one of the most um, like painful memories for me as a as a professor in the classroom. I've seen examples that give me great hope, and I've seen examples that are incredibly discouraging. I could share with you examples of courses where I have tried to explain to people the importance of um, gaining support for your ideas from all people, not just people who think like you, and been told by students, well, why would we ever do that? Like,
Mm,
you know, those people are the enemy. And, that sort of thinking really only has one, sort of end game, I think, which is like, like revolution or, or conflict, which I don't think is productive. And
yeah,
so that's discouraging. But I've also seen students, and I think this is increasing, in the last few years, recognizing that you know there are groups that we may not necessarily interact with in our daily lives as students or um, as public health professionals who have really different viewpoints and really different ways of thinking about the world and health and public health, and that those are valid too. And if you don't understand those, your odds of having impact to improve public health drop dramatically. And so I think that's encouraging. I think the short answer is that we haven't done enough in public health to train a generation of students to think that way and to provide them with tools to be effective. But I suspect that the field will move in that direction. I know we will at the WashU School of Public Health.
That's great. So I guess then thinking about the future of health communication, what do you think are the biggest challenges facing health communication right now? And if there is someone who's an emerging scholar or a young person who really wants to do health communication, what do you think they should focus on?
Well, so yeah, the information ecosystem is changing a lot. And in public health right now, I can think of a couple of sort of dramatic changes. So as the federal government public health enterprise has been reduced over the last 6 to 9 months, that has included a lot of the health communication offices and capacity within federal public health agencies, and the result of that is that there's not an immediate or there's not sort of a single definitive source of information and recommendations about health. So, like, that's a gap area in our information system that needs to be filled, and people are, I think, trying to fill it. So, like, that's one challenge. We've talked throughout this podcast about the importance of data as a basis of what we do and what information gets shared with people, and information, the availability of information and the kinds of information that are now available from the federal government are changing and diminished. And so that's another sort of gap area. And so I think people figuring out how we're going to fill those gaps as as kind of an information society is that's an important question. And then I also think that a big part of how people get information today is based upon what these big companies determine to be the best way to optimize their own profits. And this is, I think, more than anything responsible for the spread of misinformation, is that human nature is to pay
Oh,
attention.
you just said misinformation.
Oh my gosh,
Yeah.
the M word.
The M word. Yeah.
So it's human nature to pay attention to things that are emotionally evocative, and it's also what social media companies, for example, want. Is they want people to pay attention to things, and so they push emotionally evocative, alarming sorts of information towards people, which accelerates its spread. So you have this interesting intersection of kind of human nature along with algorithms that lead certain kinds of information to be spread. And the kinds of information that have those attributes are often inaccurate information. And the consequences of that is that people, it further divides people who, tend to think that people who don't believe this are against them. So all of that to say that I think there's a lot of sort of industry change that would make a big difference here. And so those are areas where future health educators might look to make a difference.
Okay. Our last question here. What is the narrative about health communication that you think needs to be complicated or something that we need to rethink?
Well, I don't want people to think that we can message our way out of complex health problems. That's not realistic at all, and really never has been. So I think, like, putting health communication and health information in the broader context of public health and understanding how it can make a difference. And I think at this moment, the main way that that health communication can help people is to do a better job of listening and systematically sharing what we learn from listening with people who are engaged in kind of the information environment, so that they can have some basis of prioritizing certain issues and addressing things that actually are going to matter to real people.
Matt, thank you for joining us today.
Thank you.
This podcast was edited by Zach Leonaris and Catalina Melendez-Contreras. It is supported by the School of Public Health and Frick Initiative at Washington University in St. Louis. You can access this and other episodes wherever you get your podcast, or you can watch it on video on YouTube. Thank you for watching.